Court. You see, the bone of contention that brought us here, or the concern that brought us here, was likely on the alarm that has been raised by the World Health Organization that there's going to be a crisis in Kenya and various African countries as to this withdrawal of funding by the US government. And of course, that has largely affected, the distribution of ARVs in the different countries. Well, the government maintains that we need not to get worried. For about 11 months, we are catered for. But of course, we cannot fail to get worried and therefore ask pertinent questions as to whether indeed, after the 11 months, will be good to stand still or perhaps good to flow. And of course, as we get to this, we realize that beyond that, there are very many other concerns that are being raised. Before I come to you, briefly, and this is a question that many people are asking, and perhaps even the World Health Organization itself is saying, do you suppose that the United States had the responsibility to approaching the withdrawal of direct funding, in a rather fair, slowly manner, such that we do not just wake up and, there's this executive order and we do not know what to do?
Okay. But I think we have been seeing some signals na hazijaanza leo. And hizi signals, I think the Kenyan government ingekuwa imeanza kuprepare.
Okay.
Because I feel like 1 million plus people, it's a very huge population of people who are living HIV positive. And I feel like we build up the economy. Hii ushuru inaongelelea, we are part of it because we work. So I feel like we should be part of the health cover the country, whereby we should be receiving these services just like any other person. Because I feel like we are only tackling HIV. You are telling me viral load yangu imelala niko sawa. But do you think I have also other conditions? Mtu wa sukari, mtu wa pressure. Umeniambia viral load yangu imelala uko sawa.
Yeah.
But where will I get those other lab tests zenye? At least we have been highlighted.
Yes.
Let's say maybe baki viral load na ni peke yake, si ndio? What of other things? Kitu kama kuangaliwa kama figo, maini, nini. Where will we get those cash? Kwa sababu we have always been knowing sometimes tumekuwa tukifanyiwa hizo vitu free. Unaona? And then when we come back to the issue of stigma, let's go back to the drawing board. Atusemi integration ni mbaya, but we should ask ourselves, mbona CCC zilikuwa zinatengwa kando? Unaget? Okay. We need to also find out why that was happening.
Okay. And we want Angela to respond to that. But also, do you think it was inhumane for the United States to just wake up and decide that they're pulling out this funding? Do you think wangeipeleka systematically so that they allow us to catch up?
I think the signals zimekuwa, and I feel like either way, our president is root in the country,
okay.
Kenya. So I don't feel like we should be talking about Trump thing. We should be talking about Kenya.
Okay.
We are in Kenya, so our issues need to be addressed by the government of
Kenya. Fair enough. Let's listen into what the government of Kenya has to say as to this, and then we come back to you.
Ladies and gentlemen, we are pleased to report that we have secure stock levels of key ARVs and testing kits, with supplies ranging from several months to close to 2 years. Specifically, we have adequate supplies of TLD, pediatric ARVs, nevirapine suspension, and other HIV testing commodities. We are also ensuring consistent availability of early infant diagnosis and viral loading test reagents. Secondly, abacavir, lamivudine, these are dispersible tablets, packs of 30s, which is the first-line ARV in pediatric patients administered together with dolutegravir. Currently, there are over 326,000 packs at KEMSA, translating to over 7.4 months of stocks. There are plans to introduce a fixed dose combination for August 2025, and we have over 18 months of stock of this product which are on order with scheduled deliveries from June 2025 onwards.
I hope that comes in handy to give us confidence. But let's talk about, a healthy youth, like me, in terms of creation of awareness, in terms of speaking to the youth to engage in safe sex, in terms of making sure that they are part of this conversation with knowledge good enough such that we can talk about abstinence, such that we can talk about protection, preventive elements, as opposed to, anything curative, maybe before it gets to that.
Okay, thanks again. On the topic is health, which is SDG 3. We have a very huge gap whereby the Ministry of Health has never really integrated the advocacy and policy engagement with the youngest population, which is the biggest and the most risky in terms of HIV. So the conversation will be, even most of these things being talked, most youth who involve themselves are on private organization, community and stuff. But the Ministry of Health has never really given that space to partner with the young people and say, those youths who are doing advocacy in matters of health, we are working together to empower you to continue with the advocacy, and even when they're coming up with policies on, now that we have this gap, how are the youth going to fit in? But rather, the ministry is always waiting for them to react when a problem comes, which is a very bad way of leading a very important sector like health.
Okay.
We can't wait until when the young people are dying every day. Then the ministry says, we want a seat with the youth.
Okay.
No, we refuse that. We want the ministry to create a space whereby they will be involving the youth in advocacy, in policy, and also even sometimes financing such youth who are doing peer education in primary school, high school, universities, because not all universities are capable to do that. The University of Nairobi does it every semester, like big 1 week for advocacy, but then the students within can be able to talk to other students, those who are passionate. But not all universities are capable to do that. We also have so many young people in rural areas. What happens to them if the Ministry of Health is just assuming that, oh, these things happen in schools? There are so many young people who are not in university and colleges, and they also need to be, get training and advice about sustainability. And as I conclude on this, I will say, we have matters of harm reduction. Harm reduction will easily work for us as the youngest population in the country. And that still needs very big will from the ministry. Okay. Because it's so funny, other ministries which are not important, they have goodwill to work with the youth and ensure things work around. But ministries which are the backbone of our life, which is health, they tend to always do things shutting down the young people. And it is a problem that I think it has happened from the onset of the independence of our country. But now we talk and say, time is up. Time is up for the ministry to work with the young people.
Have you reached out?
And
are there openings to reach?
So we were doing harm reduction last year, mid of last year, but it was basically harm reduction of drugs, because if you know, there was this drug that young people were taking in the coastal region, and then they will, someone will just be stuck for, in an unmovable state for an hour or two. So we were trying to tell the ministry, can you put more effort and energy to find out, first of all, which kind of, drug is this? And then, second of all, to educate the young people, the effect, and if they're addicted. Like, for example, for tobacco, people can use vape instead of cigar. But then these are new things that we don't know. The ministry said nothing, and of course, I don't want to say much, but you remember that lady who went to face the CS? What happened to her?
Interesting.
Yeah.
Well,
so
what happened to her? And of course, we're not in the business of pointing fingers, but equally, some of these concerns must be raised and must be addressed. Angela, we come back to you. Perhaps, you look like you have the face of the government at this point to respond to some of the concerns that are
so many questions,
Critical concerns are raised here, including that very last one. And there's that element of integration that people are talking about, or the lady and gentlemen are talking about. Just how well engraved in policy is it, such that then it would come in to address this concern of stigma, address this gap that exists in the communication chain?
Okay, so maybe I'll address her question about engagement with young people. So at the council, we have what we call the Maisha Youth. I've had some of them saying they are part of it.
Okay.
And we have 47 chapters across the country. It would be good that perhaps she gets engaged with the Maisha Youth chapters. And then we also have the county coordinating mechanisms where we have the CHMT, that's the County Health Management Team, and there are young people, Maisha Youth, who are part of that group. Regarding integration, I know that across the country, counties are doing integration their own way. And I've heard him say about Nakuru. So what the plan is through NASCOP is to check what models are counties experimenting with.
Okay.
Because integration means very many things. Maybe between Dr. Samuel and myself and Shamsa, we see integration in different perspectives. Some people see it in terms of locating of services together. Other people, it's about systems, maybe your data information systems, you need to integrate them together. So for different people, it means different things. And we also are aware that counties were integrating based on services. Therefore, it increased workloads. So the plan is to see which model works best for where.
Okay.
Yeah. Once we determine which model works best for where, is it cost effective, then we will do a guidance, a policy guidance. So there is a plan to develop a blueprint for the whole country.
Is this being communicated to the affected, to the...
So there was a summit last year that was delivered through NASCOP to just have a conversation about integration well before this happened. Okay, and there are continuous webinars in terms of what counties are trying to do. So I think there's just maybe what we need to do is talk about it a little bit more.
Some more.
Because I know it's creating a bit of anxiety, especially for the recipient who's receiving that service.
Okay.
Regarding funding, as Dr. Samuel was saying, last week we met with governors, members of parliament for the health committee and the budget. Cabinet is apprised of this matter. They are aware of what is happening. Through the policy budget statement and the current supplementary 2, we have requested as Ministry of Health, as a council, to get more allocation to buy medicines, to also have an emergency kit where we are able to, at the short term, pay these healthcare workers. As Dr. Samuel is saying, majority of the money from the US government was to pay healthcare workers. And that is the reality of what we call a vertical program.
Okay.
When HIV started in the 80s, there was a design. What we are hearing today is what that design was. People to support somebody. So now we have to ask ourselves, going forward, what would be the minimum requirement to support that person? Because that we cannot continue with that model, because if the USG has pulled out, the other day I had an adherence counselor come and see me, telling me he doesn't have work. And it's because of what has happened. So what is the model that we adopt as a country? People are doing different things across the world. South Africa, for example, they are buying their first-line treatment as a country. So what will we do as Kenya? So for me, I think the next couple of months are very determinant for the country, because then we'll be able to set in place what service delivery models we want.
Okay.
Can we afford them? We have to live within our means. Yeah.
We have testing kits?
Yes, we do. In fact, so let me read for you. Condom kit. World Safari Rally. We are there with Nakuru County.
That is Nakuru County.
That's what the same model we used last year.
Yes.
to engage with the World Safari Rally is the same model we'll use for this year. I'm aware that initially, even before the disruption of services, there was an initial delivery of 9 million pieces of condoms, and then another 1.6 that was done the other day. There's an expedited delivery of 121 million pieces. But you know what fascinates me about this country? I was driving, when we were coming here, there are big billboards of alcohol, whiskeys, very expensive. So these condoms that we have are for high risk, and the doctors here will tell you, the ones that we provide for free. What we're trying to do as a council is to do a total market approach where people are able to buy. We've even done a study in this country. People are willing to buy a condom. If you can buy a bottle of whiskey, which is 15,000, why can't you buy a condom?
Interesting. I'll be coming back to you, ladies and gentlemen. Why can't you? Why can't you? But research is critical if we're going to chart the way forward, if we are going to change tact for the better. When we're looking at this, loss of funding from the U.S. government, and we just want to look at the future of basically everything, where do we place the future of HIV research, that is including vaccine development, as well as innovative treatment methods? And I know, like Dr. Samuel says, that as a country we are capable, yet we are not doing it. I mean, what do we do here in Kenya and across the continent?
I mean, research has been interrupted. That's just a basic fact.
Okay.
You see, there are different levels of research. We have research that is ongoing, especially with, like, we're looking at people who've been diagnosed in childhood. They've been taking this medication 30, 40 years. So remember, you're looking at how have these medications been affecting them for this 30, 40 years. These are people who are now living longer. So they are getting all these diseases. If you have HIV, you have 1.5 times more chance of getting diabetes, hypertension, cholesterol issues. So you see, there are those studies that go on in these populations continuously.
Yeah.
We have studies that go on in vulnerable groups, yeah? So these are the groups we're talking about, whether it's a commercial sex worker, whether it's men having sex with men, those kind of vulnerable groups. You have studies going on with youth, studies going on with basically anyone in this who's been affected by this. And then we have the studies going on new medications. Remember what we were looking at, the rainbow that we were all looking at was moving from tablets to injectables. What we wanted was to free our populations from having to swallow a tablet. You know, wherever you go, you need a pill in your pocket, you have to move like that. We wanted them to come in, get a jab, see you in 2 to 3 months. All of those things have been halted. And you have to understand, even at the level of people who are doing some of these studies in the US, it has also been halted at that level. Forget just about us. There's so many people who've had their funding pulled on ideas that they had already been given permission. That means we're going to lose even the concept of things. And the truth is, whether we like it or not, unfortunately in Africa, we may have the bright minds, but you need the money and you need the technology and you need a lot of things behind it. And we have also been held back, meaning I can have a beautiful idea, the 4 of us can sit and come up with a beautiful study, but we don't have the $2,000 to try and publish it in, NEGM. Even if I want to get a visa to go and present something, you'll find I'm not getting that visa and I'll probably have to get my counterpart to sign off on it. Yeah. So research has really been disrupted, and we are going to feel this ripple effect much later. We're losing that, and then you lose the incentive and the innovation to even try and do these things.
Wow.
So it is massive. It is really massive.
There's going to be a long-term effect to all this
Definitely.
eventually. Doctor, I'll be coming back to you perhaps to get to know what local NGOs and advocacy groups then are doing to make sure that, number one, they mobilize resources, if any, if they were not dependent on the funding, that is to raise awareness about the potential impact of this particular funding act, because it's important that we engage government to speak to the people, but equally, we just know how instrumental the NGOs and advocacy groups have been in terms of making sure that there's creation of this awareness. But King, you have any demonstration? It's important that we have some demonstrations here, what people need to do. Is it from you that we have a demo? Very quick, in the best interest of time, because then we're also talking about abstinence or safe sex, right?
Yes. And allow me to say something.
Yes.
A former president, said...
Let's have the mic up.
Yeah. US money is their money.
Okay.
Is their taxes money.
Uh-huh.
And we did... whether I can have a team to demonstrate that.
You could use mine. You could use mine. You could come use mine. Meanwhile, what do you have to say about what you hear from the Ministry of Health, but at the same time from what it is that Angela says in terms of just trying to bring us to a level where we have confidence that everything is in control?
Okay, thank you so much again. Okay, I've heard from the ministry, from the CS Health.
Yeah.
Amesema ati dawa ziko na wamefanya the orders.
Right.
But tunajua sasa tambo ifike kwa facility itakuwa imechelewa. Kwa sababu yule mama ananyonyesha, anakuambia sasa nitanyonyeshaje mtoto bila prophylaxis.
Right.
Unaona? So it's either utamwambia aende kwa facility ingine kama anaweza pata ama a stop breastfeeding.
Are you people allowed to refer such that maybe you write a note to say, please consider this case that is special and all that? You're allowed
We are
to do
allowed
that?
to refer.
So what would be your message to the government this evening? Harakishe, fast track, or what exactly?
Okay, uwezi waambia warakishe kwa sababu amesema already ziko ordered na ziko zinakuwa supplied. So it's just upon us to continue to empower the community. We continue to empower our recipients of care. They be careful. Juu hata hizo viral load bada hakuna tubes. So we just educate them on how to keep themselves. Wameze dawa poa.
All right, beautiful. King, how quick can we do this? Because we only have about 5 minutes that we all have to share amongst ourselves.
One thing that we have to agree.
Because she came, Mike.
Yes.
Okay.
Even if Kenya, we can say that people can buy Mzinga for $15. And people don't make decisions when to make money.
Okay.
A lot of people, maybe they go to party without those plans. So they buy Mzinga and not buy corn. Because they are not prepared. But when they get drunk, they want to engage themselves into sex. So, and one of the things that we say, you come for dinner, wacha tukule kuku, unakula kuku, then you also become a dinner to somebody. Now, in this chain, and in this chain, what you are having now is something that is very unique. That a lot of people, these are married couple.
Okay.
And they are safe. They don't go even for a HIV test. They trust one another. But this guy, where he goes for kinyozi, you know, there's a very beautiful girl, and they click. And this girl is very comfortable with this man. And the secret is this girl knows the wife, and the wife doesn't know. And this guy know the two of them. And then when we talk about condom, we have what we call the monomakonde way of using condom. They use the first week. The second week, they're not using condom. They trust one another. They go for a HIV test. Then they stop using condom. But this girl has another, the landlord, or the boss, or somebody, or the PA of the governor. You know, we have these people who have money. You know, money talks. And this lady has the pastor in the church, or a choir master. That the chain goes
on and on.
On and on. And this lady, this guy also have a very young girl, a college girl.
Okay.
This is a lecturer. This girl is in internship. This girl have the official
Boyfriend.
Where is the boyfriend? Ni mzee sana. Ndio huyo, this is a boyfriend.
Na huyu pia akona bibi. You see, there's also the curtain. They have another people behind. Now, this one also went for gym. Okay.
This is a gym instructor. A gym instructor with the Buddha guy. Okay. Seriously, we need to do maombi for Buddha guys. And this man had sex with the house girl in the morning. No.
They are my friends.
They are my friends. This girl, these are house girl.
Okay, as we sum it up.
The house girl also had sex with
security guard.
The police, or the chief, the area chief. The area chief also with the headmistress of the nearby school. All this chain. This is a chain that you are trying to stop.
So what is the message here? Abstain or do what exactly?
No. We cannot tell adults to abstain.
Okay.
We cannot rock sex.
So what
it was God. We are given by God. What we need is responsible sex. And we put condom. And we tell our government, number one, reduce taxes on condom. We need condom.
Okay.
By the way, all these, we can compare one ARV. I don't know whether we have ARV. The cost of ARV is how much, Daktari?
We said the cost of
Annual.
1 year
1 year is 15,000.
is 15,000.
15,000. There is nobody who can use 15,000 condoms worth
Of
condom within a year. Unless you put all over, I don't know, you put them like a balloon. We cannot. We need.
We have not even talked about PEP and PrEP as well.
You imagine, we have not talked about PEP and PrEP.
Okay.
And if they are missing, you see, one of the biggest things.
As we close,
Yes, as we close, the burden, the hospital, the capacity of bed in our hospital. If all these ARVs, our hospitals does not have the capacity to have people bedridden because of illness. Okay. So we are going to see our brothers in hospital lying on the floor.
All right.
And the burden of the doctors.
Safe sex is important.
Safe sex is important, and we need support to go to Vasha. Daktari, please support me to go to Vasha.
That is a declaration that has been made live. Support. Only one person here to wind it up for us, and then we'll come to this side for parting shots. We'll make it very brief, around 30 seconds. Okay. Who goes first? Oh, who goes? All right.
Okay. Mimi naweza sema, for now, there is a lot that is going on. We need a lot of clarification. As Daktari has said on integration, kila mtu anaichukulia kivyake. So for now, we don't have a clear message on what is integration. So when you try to do such things, I would also request you make use of community leaders, of people who are living HIV positive, get those ideas they have, listen to them on the ground so that you can use the best approach. Thank you.
All right, fair enough. 30 seconds on this side as we close.
So thank you very much.
The call to action.
The call to action from AIDS Healthcare Foundation. AIDS Healthcare Foundation has been affected in one way or another, although we are self-funded, but we work alongside partners, strong partners who are funded by PEPFAR. And I agree with the young man there that we need to focus domestic resource mobilization. This is the sure way for sustainability. And in this vein, I strongly advocate for inclusion of HIV-related services into the social health insurance fund. I have not had any justification from anyone, including the PS whom I have talked to and the CS who I have talked to, who have been able to defend the reason why HIV clients were excluded in the social health insurance. We cannot talk about universal coverage when we leave out 1.4 Kenyans out of a national insurance fund. Yet these people are also tax payers.
Okay.
They are also contributing to the economy of this country.
Okay.
The other thing on integration.
We have to close.
Thank you very much.
Yes. Let's allow the others,
My parting shot to the Ministry of Health is that you need to do better. Given that the Global Fund has trusted the President to be the lead of the financing for malaria and HIV and diabetes this year and in 2022, it means that Kenya is trusted and that the President is committed to achieve UHC. But the people at the steering wheel are lagging us behind. So the ministry should do better and ensure that they activate and implement matters of health and also include the youth in advocacy and policy matters. Thank you very much.
Fair enough, Angela.
All of us here should be champions of the message that I have said today. There is no need for us to create panic in the whole country. As you've heard the minister say, we have enough stock to last us for the next 2 years. And there is no need, because once people start to keep medicine, it creates an artificial stock out. It creates a problem. But I'm open to having conversations, especially with the young people, even as we develop this new plan for the next 5 years. How do we deliver on the services with the new models that we come up with? So I ask them to join us so that we're able to create a framework that works for everybody, especially for the the recipient of care.
All right, and I want to trust that this is the beginning of this relationship.
Yes.
Dr. Shamsa.
So I hope the powers that be are listening so that every year we stop the way we are cutting our budget in terms of healthcare. Instead, we should be going up and looking for alternative funding, and not by raising our taxes, but alternative funding so that we can own this program. And I think for everybody listening, when you keep hearing these numbers, you need to realize they're not just numbers, these are actual people. Okay. So I'd really like to commend the panel that is here because they are representative of the people who actually do the work, and keep our communities safe. It's a privilege to care for anybody who is in a vulnerable state. So I'm hoping that as a nation, what's going to happen is we're going to own this program, and even private hospitals are going to step up and do what they're supposed to do as part of their mandate.
All right. Thank you so much. Last speaker, Dr. Shamsa Ahmed, Head of Infectious Diseases, that is MP Shah Hospital, as well as Angela Langat, MBS, the Director, National Syndemic Disease Control Council. Thank you so much. Kaikai Naipamei, CEO Youth Champions for SDG, and Dr. Samuel Kinyanjui, Country Director, AHF Kenya, that is the AIDS Healthcare Foundation. Asante sana. Smiles nakumbuka. King nakumbuka. Yours was Frank. It is still, And then Maxwell. And last but not least, Santeni Sana. My name is Linda Lela. It was great having you. I appreciate you, as well as appreciate the immense feedback that we've gotten this evening. Time could not allow us to go through them, but we say Asante Sana. Of course, I was doing this whole broadcast alongside sign language interpreter Rhoda Nyamai. We close it at this very point. We look forward to see you again on Tuesday. Do have yourself a lovely night.